Everyone can see that.
I'm going to have to record these and I'll put them up on YouTube later.
Yeah, all good, all good. I don't think I've got anything that'll like get you copyright striked, but we'll see. Maybe we can get the Mumus channel taken down. So I was gonna like put a bit more effort into these, but then restrictions eased up, and so I reprioritized. But basically, how these slides are going to work, if I can get them to work, is they're just like questions from previous vias. We'll go through them. That should give you a general gist of like the lower limb stuff. I've included basically what you'll need for third year. Obviously, as you get into it, you'll learn conditions, and the learning in third year is quite different. But because you don't need this for the via, there's no point in me like trying to teach you how to sit a via. So the questions will be just from previous years, and we'll go through it like that. This isn't everything. Next year, you're gonna like probably go in and get grilled by some like orthopedic consultant who'll want you to know things that are completely unreasonable. So I won't include, all the minute detail of bony anatomy, but this will be a rough guide to lower limb, basically. Okay, I'm gonna clear my throat a little. Okay, so starting off, we're gonna just go through like the questions, basically. So I'll let you all read it. If you want, we can probably just chuck an answer in the chat, or if someone wants to pipe up with an answer, we'll go through it that way. The answers are all on the slides, so if you're not sure, you can always just go to the next slide. But anyone got any ideas? Because there's like so few of you, I will just like call out names, and if you're not happy to respond, that's chill. But all right, anyone? Well, we'll start with Edmund. We'll just go through my list. So Edmund, what do you reckon this one is?
Maybe C.
Maybe C? Yes. So that's exactly right. So if we look at the ligaments of lower limb, I've circled in red the things that you actually need to know. So the main ones are the collaterals there, the collateral ligament of the ankle, because that's the one that will get damaged when you roll your ankle on like a gutter, or when you step in a hole. So that's the most commonly injured one. And then the other one that is here that is worth knowing is the calcaneal tendon, or the Achilles tendon. And we'll go through a little bit of that later. The knee has a few things in it. These are probably the best ones to know in the entire body. Everyone who plays sport ends up doing their ACL, basically. The meniscuses are quite commonly injured. So it's good to have a rough idea of them and where they sit. You'll see a lot of people with like meniscectomies and having to have knee surgery for their meniscuses. And then, yeah, pretty much those in the ACL is about it. The tibial tuberosity I've circled there because that's where the patella tendon or the patella ligament attaches. And that has some value in terms of clinical signs like effusions and looking into that sort of thing. Then we've got the hip. Again, not much here really. The labrum I've circled as important because in fractures of the hip, where the head is dislocated, the femoral head is dislocated, you'll often see labral tears. You can also get labral fractures, where the labrum pulls bits of the bone off either the hip or the femoral head itself. And then we've got the ligament of the head of the femur. Now, the main reason that one's important is because it has the artery to the head of the femur running through it, which in adults is useless, but in pediatric patients can be enough blood supply to keep the femoral head alive if they have a neck of femur fracture and get the sort of avascular necrosis and the damage to the blood supply in the neck. So we'll move on. All right, Sam Clark, you're up next. Damn. All right, you can do the next one. So this one, again, these questions were pretty common, but we'll just skip through it. It's not really important. In terms of when you're learning your anatomy for next year or just learning anatomy generally, it's all well and good to like know everything about a specific part, but I put this one in here more to illustrate a point. And that is that what you really want to try and learn is not just the thing, but the thing around the thing. Oh, everyone's leaving. That's fine. In this case, we've got the posterior, the sciatic nerve, and then posterior to that is the, not posterior, anterior to that is the femur. So it's the same case in the abdomen. It's the same case in the thorax. You need to know not what is there, but what is around there, because it's the things that are around your structure that are going to be damaged. So in this case, if you have damage to the femur, you can then damage the sciatic nerve, and that's much worse than damage to the femur usually. If you have, for example, in your abdomen, if you get like a duodenal ulcer, then you can get damage to the duodenal artery. So learn the anatomy around the structures as well, is basically what I'm saying. All right, MRI. Sam, do you want to have a go at this one?
Okay. Is it D?
It is. Yes, it is. I want to say it. I'm not actually sure. Yes, it is D. Yeah. So, like, just the bones of the foot and like the bones of the hand. No one really wants to know them, but you kind of have to just learn them. Find a mnemonic. I don't have one, which is why I answered that question with such confidence. But yeah, just you kind of just have to learn these things. So, I mean, a lot of bony anatomy is like that, where you just have to get through it. All right, next one. Who is up next? Isabel. Do you want to have a go at this one? It's all right if you don't.
Yeah, sure. I don't know what something else then.
What was that, sorry?
Would it be F?
Okay, so this one is, again, like a classic sort of faculty question. I think it definitely could be F. I said it was G. And the reason for that is because it could really be either. So in terms of where the blood supply is, you're exactly right in saying that it's F. But in terms of what is going to be endangered by it, it'll be G. So these questions, like, not particularly good, but the main point of this one is just to go through a little more bony anatomy and just to remember that when you get a neck of femur fracture, you can lose the head of the femur. And that's very important for next year, because almost every single old person you see in the hospital who has had a fall will end up with one of these. I was only in for a few weeks this year and I saw so many neck of femur fractures. All right. Tib fib. Yeah, just like don't say the names wrong to a surgeon. It's probably the main thing. There's some surface landmarks I've circled there, but for the most part, there's not much to learn. All right. So neurons and nerves. This is probably the highest yield part of lower limb. So if you're going to learn anything from this, just try and learn a little bit about the nerves. Who do we have up next? Natasha, do you want to have a go at this one? And as I said before, guys, if you don't want to do it, that's all good. But, you know, no harm getting it right, no harm getting it wrong. I really don't mind.
I've probably been zoning out for the last 5 minutes, sorry, so maybe not.
It's all good. All right. So, I'll do this one, and that's fine. So in terms of this one, this is like extremely specific and wasn't something I knew. So it's deep fibula, I believe. Yeah. And this is just in terms of learning your dermatomes and learning your like sensory innervation, basically. So the main thing here that's sort of clinically useful is that when you get a fracture to the head of your fibula, which is this part up here, you can very easily damage the common fibular nerve or the peroneal nerve, which can then lead to deficits in your deep fibula or your superficial fibular nerve. And that's where you get your classic foot drop sign. So a lot of people, I'm sure you've all heard of foot drop throughout the year, but a lot of people who do get this injury will end up with a foot drop. And this is a really, really sort of buzzwordy question. So you'll get a question about this at some point, guaranteed. Not this year, obviously, because you don't buy it, but next year. Okay. Edmund, you want to have a go at this one?
Sure. Let's have a crack. No, the degeneration of the hip or a normal knee. Sharp and highly localized. I'm going to say femoral practice.
Yeah. So this one's actually a bit of a rough question. So half of the hip and half of the knee are innervated. Well, the hip is half femoral sciatic, and the knee is innervated by the sciatic nerve, the femoral nerve, and another nerve. But in terms of this is answering femoral shows that you understand that the femoral is sort of going down past the knee. I'm sure, did you guys have Michelle Lazarus this year and last year when you actually learned this? So every time a nerve travels over a joint, it innervates that joint is basically the rule. So if the femoral nerve and the sciatic nerve travel over or past the hip joint, therefore they innervate the hip joint. They do the same with the knee joint, therefore they innervate the knee joint. So really either or, I think this would have been one of the questions that ended up getting cut because it doesn't have an answer, so to speak. Okay. And then it's just sort of your femoral nerves. I like these pictures. I think they're pretty good. They give you a decent sort of understanding of the course of each nerve. So the femoral nerve, anterior compartment of the thigh. Then the sciatic nerve is the posterior compartment. And then the last one you have is the obturator nerve, which is the medial compartment. Really, that's about all you need to know about their innervation within the thigh. And then beyond that, it's sort of sciatica is about it. All right. Sam, you want to have a go at this one?
Yeah, sure. All right. There you go. Female, other, cyst. thigh. Ooh. A, maybe.
I believe that's correct. Yes. Okay. So this one is a bit of a mix, dermatomal question and also about nerves individually. So the bit I want to show you is up here. This is where the we're seeing the parietal innervation of the parietal pleura, as it said in the question. But more importantly, if we go back to here, the only nerve really innervating the sort of inner thigh here is the obturator. So that just sort of makes it the answer. All right. Isabel, do you want to have a go at this one?
Sure. I'm really not sure, so I'm going to have to take a stab.
Yep, go for it. Don't worry.
I would probably guess B, but I'm not sure.
So very close. It was actually C. I would have had to take stab last year as well. Don't stress it. My tomes are very hard. I think some people last year learned to myotome dance. Some people have mnemonics and stuff for them. I just decided that I probably wasn't going to get a question on them, so I didn't learn them. Yeah, so basically extension of the knee is L3 and L4 though. And so if we damage one of those, then that's most likely where we'll have issues. Okay. This is more innovations. Edmund.
Jeepers. I reckon I've seen this. Is it like sural? I'm not really sure.
Yes.
Yeah.
No, saphenous. Close. As you can see, I'm getting them mixed up as well. So the saphenous nerve is the interesting one because it's actually the only branch of the femoral nerve that comes into the lower leg, and it has no motor function. So the entire motor function of your lower leg is controlled by branches of your sciatic nerve, and the saphenous nerve just supplies the medial aspect of your lower leg with sensation, and that's I'll probably actually just go back to this one here. So this is the saphenous nerve's innervation down here, and it's purely sensory. And it runs with the, well, not with the, but sort of in the same course as the saphenous vein or the great saphenous vein. All right, Sam, you want to have a go at this one?
Sure. I've got no idea. Sorry.
That's all good. No need to apologize. So this one's the tibial nerve. Now, this is one of the worst questions I've ever seen because it's sort of demonstrating everything wrong with the questions you get asked in pre-clin. In the real world, in the hospital, if you have an anaesthetist doing a regional block, an ankle block, they will never block just one nerve. It's completely inappropriate to do. It would never be done because you've still got then half of the foot having sensory innervation. In terms of this though, in terms of what this question is asking, the most of the sensory innervation to the sole of the foot comes from the branches of the tibial nerve. So what they're suggesting you do is you block the tibial nerve. In reality, you'd block 5 different sites around the ankle to block each of these nerves individually. You'd block your saphenous, your medial plantar nerve, lateral plantar nerve, the sural nerve down here, and then I think this is a medial calcaneal nerve. So you'd block all of those individually around the level of the ankle. But in terms of this question, it's asked for one nerve. So if you had to pick one, you'd go for tibial. All right. Isabel, do you want to have a crack at this one?
Sure, I'll just have a read.
Take your time.
Oh man. Again, really not sure. I mean, because I was thinking it could be to do with the sciatic nerve. Yeah, I'm really not sure. I'm sorry.
No, that's right. That's right. So this is nerve roots, and these ones are actually quite hard. Now, I think it's posterior L4, but okay, yeah. So this one was one of the more, like, I guess this is one of the trickiest questions here, and it takes this sort of like nerve root knowledge that is very, very or it sort of seems very low yield, and then when you get into next year, people will start asking about nerve roots and start asking about dermatomes and myotomes. But in terms of this one, the main, I guess, crux of this question is that the perineal nerve and the tibial nerve are what are held together to form the sciatic nerve. Now, the common perineal nerve comes from the posterior divisions, and then the anterior divisions give off the tibial nerve, which means when we have this question, the person has impaired sensation on the dorsum of the left foot, including the big toe, and weakness of foot dorsiflexion and extension of the big toe. So we know that they've damaged their perineal nerve. However, their knee jerk and their ankle jerk are both normal, which means their tibial nerve has to be intact, because the tibial nerve provides motor function to the muscles of the calf, which supply the ankle jerk reflex. So we know, therefore, that it's just going to be the posterior root or the posterior division which has been damaged. And then here I've got a little mnemonic, if you want to know, which is the perineal and posterior both start with P. And then tibial and anterior don't start with the same letter. But, you know, you have to take what you can get with these mnemonics, I suppose. Okay, this is a long scenario. I think the gist of it was someone decided to lift something in a twisting, jerking motion with their lower back, and herniated a disc. All right, yeah. Okay. Yes. Okay, right. Who are we up to? HS. Do you want to have a go? Oh, I've skipped it. It's all right. Don't have to show this one saved. So this one, again, is your lumbosacral plexus and your myotomes. When I was trying to do it, spent way too long on it, and sort of tried to go into all the nerve root anatomy and ended up confusing myself. I think they basically just want you to say it's an L3 injury, and so they're going to lose their quadriceps, their knee jerk. Here is a little mnemonic down the bottom, which can be helpful for learning like knee movement and the myotomes that control that. You can use it if you want. As I said, if you guys have learned to myotome dance, then that works too. All right. These ones, in terms of specific anatomy, you don't really need to know the specific anatomy of the vessels in the leg. All right, we've missed there. So you don't need to know the specific anatomy of the vessels in the leg. It's good to know your arteries, but there were no questions on it in any of the VIAs you guys have access to. The main thing that is of significance to you is learning about DVTs and a little bit of arterial stuff that we'll go through. So I've skipped this one, but venous return from the lower leg. Here are some of the veins you should learn. It looks like I've circled a lot. Most of them are just the same veins on two different pictures. Now, in terms of this one, like this is one of the questions where you don't actually need to know much at all to get it. So obviously if a clot is coming from the left side of the heart, it's not going to travel through the entire systemic circulation and then come back into the lung. Same goes for the pulmonary veins because they're taking stuff away from the lung. So as a general rule for next year, if you have a clot and it's in the left side of your heart, it's going to your brain, or it's going to go and give you an ischemic limb. Generally the brain. So people with arrhythmias will get strokes because they have clots coming from the left side of their heart. Now, if you've got a clot coming from the systemic circulation, so from your veins or from the right side of your heart, it will go into the lungs. So the lungs and the brain sort of provide these two classic bottleneck points where you're going to get clots catching and you're going to get infarcts. So this one, you could just do process of elimination really, and not know anything about the circulation. All right. This one, they do questions on every year, and you'll probably get a question on this for repro. So who were we up to? Sam, were we up to you? It's all right. I'll get you to answer this one, Sam.
Okay. Sorry, once again, I've got no idea.
That's all right. That's all right. So this is one of a set of two questions they'll give you guys. And the answer to this one is the bilaterally to the superficial inguinal lymph nodes. So the lymphatic drainage of the pelvis, you're almost guaranteed to get a question on this for your repro. So this is worth learning. And the main reason they do this is because they think that it's really tricky, because what you do is you have your external structures. So like your scrotum, your vulva, carcinomas on them will drain into the superficial inguinal lymph nodes. However, the testicle and parts of the uterus and the ovaries drain up into the para-aortic lymph nodes. So just try to remember that the more external ones, or the more superficial structures, like the scrotum and the vulva, will drain to the superficial inguinal, whereas the deeper structures just drain straight up into the para-aortic lymph nodes. All right, we've sort of done this question already. Isabel, are we up to you now? All right, you can answer this one.
So it nearly got me with the most likely to lodge, but I think, would it be within, oh, I'm a bit confused because I'm just thinking which one's the artery and a vein. I think it's a pulmonary artery, but
Yeah,
yeah.
that's exactly right. So this one's pretty much what we were talking about before, and you're exactly right. The way I remember it, and the way that I've sort of always learned it, is just that arteries carry things away from the heart and veins carry things towards it. So I don't try and think about it as like oxygenated and deoxygenated blood, because then I just confuse myself. So arteries, in the pulmonary arteries, take it from the heart to the pulmonary circulation, and then the rest of the arteries take it to the systemic circulation. Now, DVTs are quite high yield. They happen a lot in hospital. They're a very important condition to be able to think about and be able to manage. Post-surgery, they're a huge risk. And sometimes they happen on flights and things as well. But within the hospital environment, it's really important that you understand your DVT prophylaxis and what we can do to reduce DVTs. And they're all sort of based around these Virchow's triad, which is something you'll get asked about when you're on placement next year. A consultant or a reg or someone will say, what causes DVTs, or what increases your risk of DVTs? And you basically just have to, or you don't have to be able to do anything, but it helps if you can spit out the Virchow's triad. So stasis, vessel wall injury, and hypercoagulability. So people post-surgery usually have vessel wall injury because they've had surgery. They usually have stasis because they're just lying in bed. And sometimes they do have hypercoagulability as well because they're in an inflammatory state after their surgery. Other things that increase your coagulability, cancers are a big one. So people with cancer will need more drugs to stop them getting clots. There are blood disorders that give you hypercoagulable states. So just trying to remember this one and thinking about DVTs, because PEs, as I'm sure you guys have learned, that's a medical emergency, life-threatening. DVTs, not so much, but you do want to get on top of them quickly so that you don't develop a PE. All right. Edmund, you want to have a go at this one?
Yeah. Ooh. These are in the body, don't they? So it's like para-aortic.
Exactly right. So this question actually came up on 2 VIAs, 2012 and 2014. It's a bit of a classic question that they like to ask. And here's a little picture demonstrating what I was talking about earlier. So the drainage from the testicle, unlike the scrotum, which goes sort of out into the superficial inguinal, it just goes straight up into the para-aortic. And if you think about it, that does sort of make sense in terms of its blood supply coming from I guess on the left side, the renal vein and the renal artery, or the renal artery, I should say, and then coming back up. So yeah, these deeper structures, they always go up to the para-aortic. Basically, I won't go through it again. All right. All right. Sam, do you want to have a go at this one?
Yep. Most likely. Is that through the thoracic duct, E?
It is. So lymphatic return from the lower limb is really easy because it's all from the thoracic duct. The only parts in the body that aren't the thoracic duct is like the right your right thorax, your right arm, your right neck, and some of like the right head, which has its own little right. I think it might just be called like the right thoracic duct or the right thoracic vessel or something. I don't know. It's not that important. But basically, everything lower limb, thoracic duct. Easy answer, easy marks if it comes up. Okay, this one's one of the questions that I wrote. In fact, it's the only question I wrote because I couldn't find any questions on lower limb arteries, and I thought it was worth knowing. So, Isabel, do you want to have a go at this one?
Sure. I was gonna say popliteal because I think that's where it's lodged, but if it's asking where it is arisen from, I would guess femoral.
So you actually are on the money the first time.
Oh, okay.
So what is this pulsatile lump? Can someone tell me?
Like an aneurysm?
Exactly right. So pulsatile lumps are almost always aneurysms. Axillary, popliteal. Now the popliteal ones are important. Aneurysms are most important for two reasons in, I guess, the popliteal aneurysms. The first is they provide an area where you can get stasis of blood flow because they're an abnormality in the vessel wall, and you get turbulent flow there, and it's effectively like the little outpouching you have in the atria, which gives you clots. So first off, you can get clots, which can give you an ischemic injury, like this person's foot. Now, the second reason is that 15% of people with a popliteal aneurysm will also have a AAA. So if you find a popliteal aneurysm, that should warrant an ultrasound so that you can check if they have a AAA as well. Because whilst they're not going to die if they get, an acutely ischemic foot from a clot, they will die if they get a ruptured AAA. So checking this one. And the other thing is, the other one they will always ask you for, like back of the knee lumps, is Baker's cyst, which will just be generally, I think they call it like a painless non-pulsatile lump or something. And that's just a little synovial outpouching. Now, in terms of your arteries of the lower limb, I would only bother learning the ones you can feel a pulse for, because the only people who ask you about this will be the vascular surgeons, and they only care about the ones they can feel a pulse for. So your femoral pulse, your popliteal pulse, dorsalis pedis, and posterior tibial, know those ones. The rest of them are neither really here nor there. And then the last thing is, in terms of when you're palpating arteries, for a vascular exam, always do both sides. You always want to make sure that they're equal, or if they aren't equal, you know why they aren't equal. Okay. Muscles are, I could not find there were no questions on muscles. So they haven't asked a question on muscles in any of the papers they gave you. This is a very complex looking slide. You don't need to know pretty much all of it. What it is helpful for is it'll give you somewhat more of an appreciation of sort of what you see on CT. And that's about it. What I would bother learning in terms of muscles, you don't really need to know specific ones because you might get asked once in the next year. Just learn the compartments. So your medial nerve, your medial compartment is innervated by your oblongate nerve, and that's your adductors. The posterior compartment is innervated by your sciatic nerve, and that's your knee flexors or your hamstrings. And then the anterior compartment is your femoral nerve and your knee extensors. So pretty much that should be enough to get you through. The more, I guess the more important compartment is in actually the lower leg. And that's your anterior compartment, which is this compartment here. The reason this one is more important is because when you get fibular fractures, fibular shaft fractures, you can get compartment syndrome in this compartment. This is the classic compartment that people get compartment syndrome in. I always thought it was in like the thigh in pre-clin. I'm not sure why. But I found out this year that it's in fact in the lower leg. And so it's a good thing to know. Now, in terms of compartment syndrome, it classically happens, as I said, following a fracture like this. Sometimes other things can cause it as well, like really strenuous exercise apparently, and that sort of thing. But the main one to know will be fractures. And you guys might have learned like the 6 Ps of compartment syndrome. They're also used for acute ischemias from clots in your limbs, but basically they're like, don't ever answer that's how you find compartment syndrome next year, because all you'll get told is you've left it too late. If a patient is reporting pain, what you do is you check with passive extension of the associated muscle group. So in this case, you would plantar flex the foot, which would extend the anterior compartment because it's usually responsible for dorsiflexion. And that will stretch it. And if that elicits any increase in pain, then you have to be worried about compartment syndrome. And you can do like pressure testing and stuff. Often ortho will just come and do an emergency fasciotomy though, because if you get this wrong, then they can lose their limb. All right. Do you guys still have Nadita? She's still there, right?
Yeah.
Surely, yeah.
Right.
Okay. These ones we'll just whip through because, you know, they are what they are. Edmund, do you want to answer this one?
Sure. So meniscal tear. When we like push the knee down, is it Trendelenburg?
Close. So this one is McMurray. So the sort of knee special test, the meniscus one I always remember because I think I had it for one of my CSSAs in second year. And it was, or maybe it was first year. Anyway, but it was, it's a really weird test because you sort of have to try and like move their knee around and then catch the meniscus to see if you can get it to like click. So it's an odd sort of test. The other ones that you should know are Lockman's test, which is used for ACLs. There's also like the drawer test, but Lockman's is sort of preferred, and then valgus and varus stress tests. All right, Sam, do you want to go at this one?
Yep. Ooh. Tom. No idea. Sorry.
Were you going to say Thomas?
Yeah, I was leaning towards it, but
you should have committed. You got to commit. Yeah. So this one's Thomas test. It's the only one that tests fixed flexion deformity in the hip. I've never seen it done. It's yeah, neither here nor there really. Most of these test sciatica. So Braggard's and Lessegues, I'm not sure. They're just variations on the straight leg raise basically, and they test sciatica. And then Trendelenburg is gluteal weakness. Okay. Isabel, do you want to have a go at this one?
Sure. So numbness. Oh, okay. I would probably lean towards B
Yeah,
to
good
try and
answer.
elicit the reflex.
I like that answer. All right. So in terms of eliciting reflexes, in an OSTI, I wouldn't do the Gendrassic maneuvers because, I mean, unless like you know that you've got time to do it, you can just say, I would do a Gendrassic maneuver to try and reinforce this reflex. But in an actual examination, it's good to give it a go. Reflexes are really hard to elicit. Some good tips I've been taught this year: put your hand over the muscle group that you're trying to activate with the reflex, and that way you can feel the flicker of the muscle. Another good thing is to sort of watch it, although I find it a bit difficult to tell whether it's moving because it's a reflex or it's moving because I've just belted them with a tendon hammer. So I think feeling it is quite a good way to do it. And given that you usually have your hand there to hit your hand instead of them with the tendon hammer, it's generally not that much of an adjustment. And then obviously these are reinforcement techniques, which are quite useful. All right. Edmund, do you want to go with this one?
All right. So non-fitting.
Non-pitting.
Oh. Is that thyroid, right? A hypothyroidism?
Yes. So I got this question, or I did this question at least, last year, and I was not a fan, honestly. So generally pitting edema is fluid overload. So the two sort of top ones that would spring to mind for me would be heart failure, congestive cardiac failure, and nephrotic syndromes. Liver cirrhosis and calcium channel blockers also can cause your pitting edema and your fluid edema. Now, in terms of like the non-pitting edemas of the leg, much more commonly, you'll see lymphedema, you'll see varicose veins, and you'll see cellulitis. Those three swellings are very common in the lower leg, and you're going to see them much more often than you would see a non-pitting edema like this. But yeah, as you can sort of see in the picture, this is from Wikipedia, someone with, very bad hypothyroidism, severe hypothyroidism, and they do get some swelling of their ankles there as a result of that. Graves also causes it, but, if the thyroid goes too far either way, you sort of end up with ankle swelling, basically. All right, I think we're almost out of questions here. Sam, do you want to have a go at this one?
Sure. Yeah. So it's weakness of the gluteus medius. Yeah.
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 Which test is this?
Is it Romberg?
Close.
Romberg.
It's Trendelenburg.
Yeah.
So Romberg is cerebellar dysfunction. And then this one is just any weakness of the glutes. If you can basically do this one on yourself. If you just like stand on one leg, you'll feel that the opposite hip rises up above the one you're standing on. Whereas as you can see here, where there's a positive Trendelenburg, the opposite or the the hip you're not standing on drops below because the glutes aren't strong enough to hold up the leg like they're supposed to. Okay. Isabel, do you want to have a go at this one?
So, oh goodness. Varus, I think would be, is it looking at the lateral collateral?
That's a very good question. Varus is looking at, yes, I believe the lateral collateral. All right. So these tests are a little bit tricky because they sort of, or maybe it's just for me. Sometimes I like think about them in the opposite way to what they're supposed to. Yeah, no worries, Edmund. We're last one. All right. So with Varus stress test, you're testing your collaterals. Varus and valgus both test a collateral each. Valgus stress test means you're trying to force the leg into valgus, like this down here. And that is going to put more strain on the medial collateral. Whereas if you think about the Varus stress test, you're trying to force the leg into Varus, which is going to put more strain on the lateral collateral. So that's basically how you test those ones. All right. I lied. This is actually the last one. Edmund, do you want to have a go at this one?
Cool. Is it ACES to medial malleolus?
Exactly right. Leg length, apparent leg length versus true leg length. You might get a question on this. I've been asked it on the wards once or twice. Not super high yield. True leg length is just measuring the leg is sort of how I think about it. So you start on ACES and you go down the leg. Whereas apparent leg length, you measure bits that aren't the leg, like the umbilicus. If that helps, then it helps. If it doesn't, just try and find another way to remember that. Okay, this one is actually the last one this time. I know I've said that for the past 3 questions. Sam, do you want to have a go at this one?
Sure. C, maybe?
Yes. This one's just feeling pulses. Peripheral vascular exam. I won't tell you how to do the entire thing. But basically, your usual look, feel, you don't have to move anything. You don't have to listen to anything. And yeah, just comparing the 2 feet, looking at the vascular supply of each. And the most common reason you'll do this is part of a diabetic foot exam, which is actually like a useful thing to be able to do. But just get good at feeling pulses and learn roughly where to do them. This diagram I think is pretty helpful. But you don't want to be doing what I did earlier this year where I was looking for the posterior tibial pulse on like the lateral side of the foot. You're not going to find it there. So just kind of get used to that. All right. That is it from me. Thank you all very much for coming and for participating. I know obviously not the highest yield stuff, but hopefully you'll find something useful there.